So please welcome Kristen Stockard. Kristen has been a clinical social worker for nearly 30 years with 20 years of experience working in pediatric dialysis and kidney transplant. She recently received her DSW from the University of Pennsylvania, transitioning from clinical practice to teaching and scholarship. Her research explores the roles and responsibilities of social workers that are passionate about health equity and considers medical ethics to be an important area of expertise for social workers in the social justice fight for healthcare access. Please welcome Kristen.
Thank you very much for that. I have told I need to stay by this mic, and I have a tendency to wander when I talk, so if I drift away, please just wave at me or something. And the buttons on this computer are being a little slow, so I'm going to try and make sure that I'm correctly getting to the slides that I want to talk about. Hi, welcome, good morning. I hope you have all had a good morning so far. This is what I want to try and talk about today. I want to sort of set a foundation for us about our code of ethics and some ethical frameworks that we rely on in transplant. I want to talk then about the history of the early days of dialysis and thinking about how what was termed the God Committee that helped select patients for dialysis early on translates into how we think about transplant selection now. I want to talk about the ethics of that. And I want to think about the 4-box model, which is a model for ethical decision-making that might potentially be a way for us to think about making the selection process look a little different in transplant, and think about how that has implications for our practice. So that's a lot to cover, and we'll see how we do. I have no disclosures to make. I am originally from this area. I grew up across the river in Cambridge, so it's really fun to be home and taking the tea here in the mornings, which is great. But I do live and work in Seattle, and so I just want to say that my work and my connection to this topic is based around about 20 years at Seattle Children's Hospital as the dialysis social worker. Early on, I was all of the nephrology, social work, dialysis, transplant, everything. And then when we were able to get a little FTE, I cut to just dialysis. So dialysis has been my main focus, but I did start with some experience on the transplant selection team there. So my experience is really grounded in pediatrics. And so that also shapes how I think about this. And our center in Seattle is in a very urban place, serving an enormous rural region. So that's the other thing that shapes how I think about this, is thinking about the urban and rural communities that need our care and need our services. So those are my disclosures. They're not financial, but this is how I come to these topics and these ideas. These are my learning objectives, which are very concrete and takeaway. But my real goal is that I hope you will take away from this talk some thoughts that will rumble around in your head about these topics and about the way that we do transplant selection. And I hope that you'll take away some questions for yourself and sort of an openness to thinking about whether we need a different way of doing things. So that's my real objective. But these are some concrete ones that I hope you'll take away from today. So I'm going to start again. I wanted to just give us a foundation to make sure that we're sort of all thinking about this in the same way. So if I think about what shapes our ethics, we start with personal values. And that really starts very, very early in our lives, right? We get most of our initial personal value thoughts from our families of origin. Oftentimes there's a religion that is either directly influencing those personal values or has influenced family generations before us that translate into our families of origin. And that's really a starting place for how we come up with our values. It's probably how you all found yourselves drifting to social work or nursing or whatever profession you're in that's connected to helping people. And then as a profession, we have a code of ethics that helps us think about the principles that drive the ethical decisions that we make and how we frame these ideas. And because we all work in a medical setting, we also have a biomedical ethics model that is important for us to pay attention to. And then I think what we don't often think about are these big ethical frameworks that give us a sort of big picture, broad overview of what sort of the primary goals ought to be for us, right? And so I think that's helpful to remember as we talk about this today. And so I'm going to talk about 3 ethical frameworks that shape how we make decisions in transplant, because I think it's important to remember what those are helping us to think about. So let's start with our professional ethics code. I'm sure you know this really well. I'm sure you have seen this in other talks this weekend, but it's really good to remember. We have service. This is how we are taking care of people. And it's important, I think, for us to remember that social work as a profession was designed in service to the poor. So when we think about service, it's really important to remember that our profession is focused on serving the underprivileged, the underserved, the marginalized, and the oppressed. And so when we think about our service in medicine, we are serving everyone, but we still as social workers have that framework that we need to be paying attention to. We have social justice as one of our principles of practice and principal ethical codes, and that's really critical and important. That's not true for most professions, and that's really something that's special about our profession, and we need to really pay attention to that, and that's going to come up a lot today as we talk. And then we have our dignity and worth of a person, the importance of human relationship, integrity, and competence. And all of those, I think, are things that we do when we practice in this field, and it's important to remember all of these pieces of that. So if we think about the 4 pillars of bioethics, and because we are in a medical profession, that we are also abiding by those and attending to those. We have patient autonomy, which is thinking about how patients have the right to make choices about their bodies and about the care that they receive. We have beneficence, which is the idea of we are practicing to do good. We are trying to provide benefit to the patients in our care. We are trying to be helpful. We are trying to provide good care. And non-maleficence is about not doing harm. So not only are we going to try and do good, but we're going to also try and not do harm. And we have to take that into consideration when we know that treatments are challenging and have difficult consequences for patients and have bad symptoms and things like that. When does that drift into a place where the harm outweighs the benefit? And the 4th pillar for bioethics is justice. And really, that sort of frame, the way they frame that in bioethics is thinking about the fairness of how we provide our care. And so are we providing equitable care? Are we providing it in a fair manner? And that's, I think, an important way for us to also be paying attention to as social workers. So if I try and put these together, this is a little bit of a messy slide, but you can see that these work together relatively well. Our code of ethics and the bioethics pillars do fit together really nicely, right? And so these are not in conflict with each other. And that's important, right? We're not being asked to violate our code in order to practice in a medical setting. And so, but the other thing is we need to bring our perspective into each of these areas of medicine, right? So as we're working with our teammates who are physicians or nurses or other providers, we need to help bring our social work focus from our code of ethics into these areas of the bioethics. And so that's helpful, I think, just as a starting place to think about how we are attending to all of these in our daily practice. So the 3 frameworks that I want to talk a little bit about, again, to help provide a foundation for us to make sure we're all thinking about the same big ideas about ethics, are utilitarianism, deontology, and feminist ethics. And it may surprise you to understand that transplant is really drawing from all 3 of these perspectives as we think about how we make decisions in transplant. These are my 3 images of how I hope you'll help remember what they all mean. I'm going to go through each of them really quickly, and then we'll move on to some other things. But utilitarianism, Spock is a utilitarian. So I don't know if we have Star Trek fans out there, but Spock is a utilitarian, right? So his live long and prosper is a utilitarian ethic. the part of utilitarianism is doing things that bring you the most joy. So that statement of his is also utilitarian. But this one, in this scene, he is saying to Kirk, the needs of the many outweigh the needs of the one. And that's really what we're talking about here. Utilitarians are trying to think about how to do the most good while causing the least harm. And so this shows up in a lot of ways. There's a lot of medicine where we think about utilitarianism. In the ER, for example, we don't have a first come, first serve system so that the person is not dying of a heart attack while we're putting a cast on a broken wrist, right? There's a way in which we are trying to make sure we are doing the most good while causing the least harm. So we're okay with that person with the broken wrist having to wait a little while so that the person doesn't die of a heart attack. And that's a utilitarian frame. We're trying to think about how we spread out our good and minimize our harm in the process. Things like mass casualty events are places where utilitarianism shows up. So if you're a physician and you are the first on the scene of a mass casualty event, you could make a choice, and in the utilitarian view, an ethical choice, to help another physician first. And that might not be fair, and that might not be equitable, but if you help that physician, then they can help you serve more people and take care of more people. And so more people, there will be more good to come if you opt to do that person first. So you can see how this is a framework that allows us to make some ethical decisions that might not in other settings seem fair, but the big picture is doing the most good while causing the least harm. And so in transplant, we think about the ways that we try and make sure that organs do the most good. So we decide that it's okay to say that a person with terminal cancer is not going to get an organ off the transplant list because we want that organ to have a longer life, right? And so we are going to limit ways in which we consider organ wasting, and we are going to limit the ways that we decide how those organs are distributed in the big idea of doing the most good, having those organs last the longest, give the most life to the people who receive them. And this is the framework that helps us feel okay about that, right? The next framework that I want to think about is deontology. And the best way to think about deontology, the best example of that is our justice system in the US. And I say that, and I want to clarify that I'm talking about the idealized version of our justice system. Not necessarily the way it is currently functioning. But deontology is an ethics of duty, and it is a framework that prioritizes the means over the ends. So the process by which we get to something is the most important thing. And so doing good, moral, just work allows us to feel okay about whatever the outcome is of that work, right? So physicians abide by a deontological framework when they do individual work one-on-one with patients. Social workers do that in lots of different contexts. And anytime we are in a personal counseling or therapy relationship with someone, we are doing that under a deontological framework. If you think about things like duties for confidentiality, duties around boundaries, duties around mandated reporting, that's a deontological framework that helps us make decisions about doing that individual work with people. And so as social workers, we do this a lot. This is a framework that we use for a lot of the work that we are doing. And so in thinking about transplant, the deontological focus would be a fair selection process is what matters most, right? And so one of the questions that I'm going to try and help us ask today is our selection process fair? But that, in this framework, is what matters the most. And another way to think about it in terms of transplant would be how we refer people to transplant, and that we are not making a decision about whether someone should be referred to transplant too early in the process. If a physician is making referrals, they are not saying, well, I like Joe better than Sue, so I'm going to refer Joe to transplant first so that they can have a better chance than Sue. That's not what we consider fair or appropriate or ethical in transplant. And that's a deontological duty to the person, right? So as we have an individual duty to our patients, and a duty to help them get the care and the services that they need. Is this making sense so far? Awesome. All right. Some people are surprised to know that there's a feminist ethics framework to transplant as well. Doesn't always feel very feminist sometimes. But feminist ethics is an ethics of care. And there's a couple of different pieces of feminist ethics that sometimes people struggle to figure out how they're connected. So feminist ethics is about dismantling the patriarchy and about a duty to care for others. And the way that I bring those two together is that in a patriarchal system, we have gendered caretaking roles, right? We have created caretaking roles as women's work, and we have created some gender identity around caretaking. And the idea of a feminist framework is that we are all caretakers. We should all care for one another. As humans, human relationship is what's important. And so taking care of one another should be a duty that all of us are participating in, and it should not be a gendered role. And so we have to dismantle some of our patriarchal structures in order for that to actually happen. So I don't think transplant is trying to dismantle the patriarchy. I don't think that's happening, just to be clear about that. But we pull a few things from this framework when we think about living donation. Right? When we think about how we decide when it's okay for someone to be a living donor and when it's not. And we, for example, in pediatrics, we are very comfortable with a parent deciding that they would like to offer their organ to their child, but that they're not ready to offer their organ to some random person that they don't know. And we think that that's okay, right? That is a feminist framework. In fact, because we are saying that there are many frameworks that would say, well, if you're willing to give your organ up for one person, you should be willing to give your organ up for all people. And there are other frameworks which would go even further and say, if we've decided it's okay for one person to give up an organ, we should just take them from all the people we think are safe to give their organs up, right? We should just collect them and redistribute them. And we have not decided to do that. And so part of that is a feminist framework. Part of that is saying that that parent has a duty to care for their child that is really important, that is a really important relationship and an important caretaking role, and that if they have concerns that giving an organ to somebody they don't know puts them at risk of providing that care to their child, we are totally comfortable with them making that decision. We are also totally comfortable with a parent saying, I am not prepared to give my child my organ because I need to take care of them, right? So this is a way of feeling okay about our living donation system. And while we want to promote living donation and we want to think about ways to do that, we also really want to figure out all of the ways in which we care for one another. And so taking care of one person may or may not sometimes interfere with taking care of another person. And so we have to make decisions about that, thinking about relationships and thinking about our big picture, taking care of each other, taking care of one another. So it's only a little piece of feminist ethics, but we draw on that, right? We bring a little bit of that into our transplant selection process. So I'm going to move on to something that's a little different than this, but I wanted to sort of give us this foundation, and I want that to be buzzing around in your brain as we think about how we got to our current selection process, so that you can remember what are the big picture ideas that we have in mind. Are these the right ideas? Are these the ideas that should be shaping our transplant selection process? And remembering where our ethical values and principles come from, and what our duty as social workers are in this process. And for other people out there, I'm sorry I keep saying social workers, but this is I'm a social worker, this is who I'm talking to. I apologize, I can't remember who I stole this line from, but The Story of Dr. Scribner and Mr. Clyde is, I think, a great title for thinking about our history here. So we have a couple of people from Seattle, so Seattleites know this history probably better than most. But I just want to make sure that we all know some of these early days. So, and apologies to folks out there who know more about these early days than this, but these are some basics, right? So hemodialysis was something we could do before the 40s, but roughly around the 40s is when it started to become we were more competent with it. We did a better job with it starting around in the 40s. And the first kidney transplant in the US was in Chicago in 1950, first human organ. But so during this time, we were doing some transplants, a few. But dialysis was entirely an acute service. So it was for acute kidney failure only. And part of that was not being able to recannulate people. And so every time, so you had to undergo surgery in order to receive dialysis, and every surgical procedure blew up one vessel or another. And so there was a limited number of times that you could actually receive hemodialysis. So it was really only considered for acute reversible kidney failure. And that's how it was used in this time frame. And then in 1960, in Seattle, Dr. Scribner started getting really frustrated by this system. So in particular, I think he had a patient that they thought maybe had acute kidney failure, came in, they started dialyzing him, and he perked way up and became really functional and competent and seemingly well. But they figured out that his kidney problem was chronic and that he would not be able to come off of dialysis and continue to live. And so they had to send him home to die, because they did not have a way to do long-term dialysis. And so Dr. Scribner was just sort of, I think, was frustrated by that and developed the Teflon shunt that would allow repeated cannulation to do long-term chronic dialysis. So this is a photo of the first hemodialysis patient, Clyde Shields, and he dialyzed for 11 years. Before he had a heart attack and died. So that's kind of remarkable, right? That the first chronic dialysis patient did that well. Just doing a little reading about him, it sounds like he was a really ideal first patient because he was a really good communicator. So he just told them what he was feeling, what he was experiencing, and they just learned a lot because he was so open about his experiences. And so they learned a lot about the symptoms of dialysis and what things were working and not working. So that's sort of, so that's 1960. This is a photo of one of my patients that I worked with, and I get to show it because it's a photo from the Seattle Times, and he gave permission for that. So the Seattle Artificial Kidney Center, which is now Northwest Kidney Centers, I don't know if we have anybody from Northwest Kidney Centers here, but they are still going strong and still a phenomenal organization out in Seattle. But originally, so in 1960, when this worked with Clyde Shields, Scribner found a couple of other existing patients that he did chronic dialysis with. And he started the Seattle Artificial Kidney Center in what was the University Hospital, which is now University of Washington Medical Center. And so he started just in the hospital serving his own patients. And once he figured out that that was working, he got a grant to open a 3-bed center and then increased the next year to 7 beds. A couple years later, he started his first home dialysis patient. And in 1967, they had dialyzed 23 patients on home dialysis. And in 2,800 treatments, the physician had only been called to the home 4 times, which is quite remarkable success for such early days of this brand new treatment. During this time, there were some other places around the country that started trying out dialysis, and none of them had the same success that Seattle did. And one retrospective viewpoint that I've read about, one thought is that all of those other places built their dialysis programs into their transplant program, because if you recall, we were doing transplants really first. And so dialysis was really, truly a bridge to transplant at that point in those places. Whereas Scribner was setting this up as a chronic dialysis program. And so I think the sort of the view in the rearview mirror is that his orientation on chronicity and dialysis as the focus rather than these are patients we're going to transplant helped shape a much more successful program for them. And so this is what's happening in the 60s, and this is all in Seattle. But the problems that came up, of course, were that as soon as they figured out that this worked, there were then way more patients than for the 3 machines they had in the basement of the hospital in Seattle, right? In one hospital, in one city, in one place. So they needed to start figuring out, this couldn't just be Dr. Scribner's patient list, right? So that they were going to try and expand, and they needed to figure out a system for determining who was going to get the dialysis care, right? So at the time, dialysis was the precious resource. We now think of that with organs and transplant as the precious resource. At this time, that was dialysis, right? And so they were trying to figure out how to make these decisions, and what they came up with was a committee of laypersons. And so this committee had a lawyer, a minister, a housewife, a labor leader, a state government official, a banker, and a surgeon. And then there were 2 physician advisors who could talk through certain medical issues with them. And so that was the starting place, is that committee of laypersons. And they were tasked with getting referrals of people that were medically qualified to receive dialysis and making a decision about who would get it, because there were 3 machines in the basement of a hospital. That was not going to serve everybody. Later, they decided to add a social worker, a psychiatrist, and a vocational guidance counselor as investigators. And you'll see that part of that was trying to figure out what some more background information about the patients that were being referred to try and make better decisions about who was worthy of receiving that care. So they had sort of these 3 basic tiers of criteria. And the first you can think of as who should we dialyze? Like who needs dialysis, right? So they were asking for physicians to refer based on medical eligibility, so someone who needed chronic dialysis. And their second tier was really about sort of the people that I think they thought were more likely to be successful. So they wanted people in Washington because they figured the travel was too complicated from out of state. And they chose between the ages of 16 and 45. And you can imagine that they were worried about not knowing how to do this with children and worried about not knowing how to do this with people who were older and might have other kinds of complications. So that's sort of a tier of like, who do we think we can serve, who can we really help adequately? And then they went to this third tier, which asked about things like the sex, the marital status, the number of dependents. They definitely asked a lot of questions about income and net worth because they needed to be able to afford the treatment. There was not Medicare yet. They asked about things like what kind of education, what occupation they had, what their past performances were like, and what their future potential might look like, right? So this was a question about, are you worthy, right? Are you worthy of our care? Are you worthy of this life-saving treatment? And so we were very much focused on on worthiness and judgment. And so this is a quote from a member of that Admissions and Policy Committee who said, "I remember voting against a young woman who was a known prostitute. I found I couldn't vote for her rather than another candidate, a young wife and mother who had proved her responsibility and worth." Right? So think about that quote. That's a very stark social worth, social judgment quote that can feel a little shocking when we read it. And I bet we kind of still do that, right? I bet we kind of still rule out people like the prostitute when we are focused instead on the mothers who have proven themselves responsible. So this is what was happening. The earliest parts of that social work evaluation, remember, social workers were coming in initially as investigators, right? So they were investigating the background of these people to help determine that social worth, that worthiness, that social value. So these are the sort of 4 categories they were thinking about. They were thinking about adjustment to illness, rating it on a 3-point scale. They were thinking about self-care not in the way that we think about it today, not in the sort of wellness concept, but in the concept of, are you able to take care of your own hygiene needs, or does somebody have to take care of those for you on your behalf? So are you able to do your own care for yourself, or do you need a caretaker? Potential for rehabilitation. If you recall, this is really how we got ourselves inserted in dialysis during the push for Medicare coverage, is our ability to help a patient who received care rehabilitate, become a functional member of society again, become a productive member of society again, increase their social worth. And stress tolerance was something that social workers were paying attention to as well. So this didn't entirely sit well with everybody. I apologize, this is a screenshot of a reissuing of this article. So the date on there says 2019, but this article came out in November of 1962. So remember, this is right after the Scribner had opened his first 3-bed clinic. So the earliest part of this timeline. So this reporter for Life magazine came out and interviewed the people on this committee. And this headline, "They Decide Who Lives, Who Dies," caused this committee to be named the Life or Death Committee, which then eventually translated into the God Committee. And this sort of stoked a more public thought about this, a more public debate about whether this was a good way to make these assessments. Some of the other people that were talking, so these are people who were not directly involved in dialysis programs anywhere, and definitely not in the Seattle one. So Dr. DeWardner was a physician in London. So in 1967, he's posing these questions, right? Is it justifiable to prolong life in this way? Who should get to choose who receives this care and who doesn't? What are the financial consequences, and who should pay for that? Interesting, somebody from London where there's a different kind of medicine. Is this expense worthwhile? Is this use of personnel worthwhile? Is this how we should be letting our nurses spend their days, right? Is this how we should focus their time and energy on these small numbers of patients? So those are some of the questions that he was asking from across the ocean. And then Sanders and Ducommunier were a psychiatrist and a lawyer. So they were not directly involved in any dialysis program. But they were concerned about this. They were concerned about the ethics around this process of having a layperson committee making decisions about who got to live and who didn't. But here's their quote: "If selection of patients by ad hoc comparisons of social worth is objectionable," right, if we've all decided that that's objectionable, "comparisons by a committee composed of physicians, hospital personnel, and social workers rather than by lay committee is no less objectionable. Medical men are no more qualified to play God, to look at 2 persons and say one is worth more than the other, than ordinary mortals," right? So these are the kinds of questions that decision-making process was posing for people. Is this an ethical way for us to make this decision? And one of the things that I think makes this discussion slightly different than our current one, but not entirely, is that, of course, the folks who would not get chronic dialysis were not going to live for very long, right? We know that people can't live for very long once they reach end stage without dialysis. So we were talking about a very rapid decline to death, and definitely these patients would die. They were not going to survive without dialysis. And with transplant, we have a little bit of a different window that we're talking about. But these are, I think, really valuable ethical questions, right? These are the questions that I think we should continue to be asking, always. Who is getting to decide, and is that okay? So there were some alternate ideas proposed about how to make these decisions. One proposal was just simply ability to pay, period. That should be the only criteria. Can you pay for the dialysis treatment? Great, you should get it. Another idea was to have a first-come, first-served list, essentially. One potential proposal was a lottery. Are these sounding familiar about the ways we think about what alternate ways to do this? One thought was to make these committee hearings public. So the committee that was debating about patient eligibility would have to do that in public so the public could come and listen to the debate and hear what deliberations were happening. And then another proposal was to make sure that the patient had a representative at that committee meeting who was speaking on their behalf and sort of advocating for them. And so I think these are all the same kinds of ideas that we might continue to think about today. So as we know, what happened in 1972 is that, in part, with some social work advocacy, but advocacy on a lot of parts by a lot of different providers in medicine, was to amend the Social Security Act so that Medicare would cover dialysis, right? And so that removes the question about who's going to pay and who can pay. And that means that we sort of can rapidly accelerate access to dialysis. So social work gets involved with this promise of rehabilitation, but it allows us to shift our focus less on the investigation, on the sort of trying to determine who's worthy, and we can shift our focus to interventions that are going to help rehabilitate people, help get people back to work, back to school, back to their productive, socially valuable lives. And so in the ethics world, this eliminates the need for selection committees for dialysis, right? So if we ramp up the access and we have ways to pay for that, then we're not having to decide who will get this treatment. We're giving it to everybody. And folks at the Northwest Kidney Center described that their new dilemma became not who to dialyze, but who not to dialyze. Like when did they have to decide that dialysis should not be a treatment that was offered? But you can see that this sort of starts to suddenly dramatically shift how people are thinking about dialysis and access. So for social workers, we have this ability to shift from who has lived a quality life, how are we valuing somebody and determining that somebody has lived a life of value, a life of quality, a life of worth, and should get to keep living, to being able to make our shift to promoting quality of life, right? So we're promoting how people can live on dialysis and live a full life. So it's a really nice change for us, right? We get to shift to a much more feminist frame in terms of our duty to care, our ethics of care for people. But we do still have some conflicting roles, right? We're still doing some amount of investigation, and we're trying to sort of shift away from that to put the focus on support, but we're still balancing those two conflicting roles, which is what we still do all the time, right? We are in constant evaluation and assessment mode and constant support and resource and facilitation mode. So these are our battles as a profession anyway. So we have some consequences for transplant because of this, right? So remember that transplant wasn't really considered a precious resource because without dialysis, there was a limited number of people who you could determine needed a kidney but didn't yet need dialysis, and you could manage to get them that kidney before they needed a chronic dialysis treatment. And And so we have this demand for transplant suddenly skyrocket, because now we have all these patients, we've put them on chronic dialysis, we're taking care of them, we can provide care for them until they can get a transplant. They all need a transplant. So we suddenly have this huge new population that needs a transplant. And so organs become the precious resource rather than dialysis. And so we have this selection process for transplant, but we stopped asking these questions, right? The ethical debate ended. So as soon as Medicare swooped in and provided that financial assurance and access opened up for dialysis, we said, great, we've solved that ethical dilemma. And those questions that we were asking didn't then didn't transfer over to transplant, because it happened in a different, it's sort of in reverse, right? So it was something we knew how to do before we knew how to do chronic dialysis, and we were dealing with limited patients who needed it. It was not a precious resource at the time. I mean, you can name precious in a different way, but the supply and demand issues were not as extreme as they became as soon as dialysis became widely accessible. And so why is that? Why did we stop asking these questions? Why did we stop asking whether we had an ethical framework for selecting patients for transplant? Is it simply because patients weren't going to die within 2 to 3 weeks of not receiving a transplant? Maybe. But I think it's interesting that we stopped asking that. So for social workers, I think one of the things that's really important is how much we are a part of this process. So oftentimes dialysis patients report that their social worker is the most significant source of information about transplant that they have. That's interesting, right? We are not the expert. We are not the most expert person to provide information about transplant. We are often the person that talks to them, right? We have more time with a patient than somebody in the clinic setting. You get this rapid fire visits with people, and there is less time for processing the information. And it's usually the social worker who, once you've processed the information, you then turn to with the questions. And we are an important figure here for our patients. Also, more patients are declined for transplant selection, or declined for transplant for psychosocial reasons than for any other reason. Now, that's excluding the people who don't make it to transplant selection because there's some medical rule out early on, right? But most people, we are saying no to most people based on psychosocial issues and psychosocial problems that we think are a barrier to successful transplant. And more often than any other member of the interdisciplinary team, social workers are the ones who end up with a dual role. So we end up being the person who is the social worker for the patient of review, and we are the social worker who is on the committee making those decisions about the review. And I'm grateful that I think, more and more we are separating those roles. But of all the people on the interdisciplinary team, social workers are the ones most likely to still be caught in that dual role. So here's my question to you. I know you're familiar with this little thing. As a social worker, when you conduct a transplant assessment or participate in transplant selection, do you consider your priority to be to the organ or to the patient? And if you're not a social worker, just answer this for yourselves. I'm so excited to see this answer. I can't tell you. When I was at the Society for Transplant Social Workers meeting, that was different. There was a keynote speaker who said that our priority should be to the organ. And that was really startling to me. That's not how I ever viewed it for myself. But again, I'd been separated from my transplant role for a while. So personally, I'm excited to see more people saying to the patient, because I think we are stuck sometimes where we're being asked to be on a selection committee where the priority is theoretically to an organ rather than to a person. As we have this resource, this limited resource, there is a necessary gatekeeping process that has occurred. So similar to what happened for dialysis, we now have a gatekeeping process in transplant, and we are a significant part of that process, right? And so there is an element of organ stewardship that is important to recognize in that role as gatekeepers, right? We are trying to take our utilitarian mindset and focus on the most good and the least harm. So we are trying to make sure that organs go to good use, which is, give the most life to folks. And so there's a part of that process that is necessary to make sure that we are thinking about how to honor the organ donation and how to make it work as well as possible. But we have these dual responsibilities where we're thinking about this organ and how to do right by that donation, and we're thinking about these patients who all need a transplant, whether we're going to give them one or not, whether they're going to live long enough to receive it off the list or not. They all need one. And so I think it's important to think about our gatekeeping role as social workers, right? So thinking about, I think there are times when social workers, I think, feel a little bit like we've been invited to sit at the big kids table when we're on transplant selection teams, and we feel like we aren't sort of the top dog on the transplant team, and we have to be deferential to the surgeon or some medical expertise that needs to be spoken in this setting. And I think what I want to say is that we come to that table with expertise. We come as the psychosocial experts. And I think we need to be able to honor that role in a much more important way. We are not just there to simply report out our findings of a particular patient who we've done an evaluation with and be recommending or not recommending them for transplant. But our role as the psychosocial expert needs to be thinking about that social justice focus and all of those ethical frameworks about the big questions of who we're giving organs to and how we're making decisions and what we're thinking is okay or not. And we need to be that psychosocial expert on this team. We need to be bringing our social justice concerns to that table and thinking about how we can promote our ethical framework within that setting, right? And so, because we know that our gatekeeping process is subjective to some extent, right? We have some objective criteria, and that's great. That helps us narrow some things down and helps us focus on a smaller group of patients. But ultimately, we're making a lot of subjective decisions. We're making a lot of judgments, and that leaves us open to being discriminatory, to being judgmental, and to having personal bias that influences how these decisions get made. It opens us up to discrimination, disparities, inequities, all of those things, right? And we know that there's a lot of disparities. So we know that we've created a system that is not equitable right now. So we know of a lot of racial disparities. We know that that's been the case for a long time. We have done some things that I think are really productive and positive. I think removing the race correction in the EGFR is a really important step. But I think we have to remember that that's a small step, actually. It can feel big, and it is big. I mean, it's an important thing. But there are so many clinical algorithms in medicine that use race that taking it out of the EGFR that dialysis programs use, is a really small drop in that bucket of healthcare disparities around race, right? So I mean, think about the big commercial labs around the country and whether all of them have in fact changed their algorithms around EGFR. I talked to a physician at a hospital who was really proud of the work they had done to change their algorithms, and then figured out that their Epic system was still using the old algorithm. And so even though they thought they had removed it, the system in Epic was still somehow recalculating all of those values. Right? So there's a lot of embedded structure that we have not necessarily removed. And there are so many other, right, where there are algorithms in cardiac care, there are algorithms in breast cancer care, in whether or not people get approved for vaginal birth after C-section. There's so many algorithms that take race into consideration that even though we're making progress, we are so far behind. There's so much left to do, and we need to not say like, oh yay, we did it. We got rid of it in the EGFR. It's still baked into some of our evaluations of donor kidneys. It's still baked into lots of other things that, especially that patients receive along the way to us, before they get to us. These are impacting so many parts of their care. We know about gender disparities. We know that women have a less likely chance of getting a transplant than men. I had the chance to do some independent research around pediatric access, and what I know from fellow pediatric social workers is that, for example, children of single parents, children in foster care, children whose parents don't trust their doctor, and children who are poor have way more problems accessing transplant than other children. And so if you were to think about those as ethical dilemmas and ethical questions, they're not that complicated, right? If we said, well, maybe we should make a rule that children of single parents shouldn't be eligible for transplant, we would all say that is not ethical. All of us, we would all say that, I feel confident. And yet, that is how our system works, is that those patients have a really hard time getting to transplant. And so why is that? What have we done? What have we created to make that happen? Part of it is that, we often, I think many centers think of the transplant evaluation process as a means testing method, right? Of thinking about, well, if you can't make it through the transplant evaluation process, you're not going to be good at taking care of your kidney. I don't know why we think those two things translate, why we think those two things are equal, right? Why we think that the way that somebody attends to a non-treatment-oriented appointment is the same as an organ-saving medication. I wouldn't evaluate those two things the same, right? If I had to choose between one of those two things, I would know which one to choose. But we've decided that one dictates how we will do the other one. And so we use this process as a way of weeding people out. And I think it's important to ask why. Are we doing that for convenience? Because it's easier to evaluate a smaller number of people when we know that not everybody's going to get a transplant. Maybe that's why we've decided to do that. Do we really actually think it's a literal translation? Do we think ability to attend 27 pre-transplant evaluation appointments is a good way to evaluate medication adherence post-transplant? Maybe. But I think we don't ask those questions very well, right? I don't think we're asking those often enough and really thinking about what the answer is. So if you'll indulge me, I just did some research around around disparities for Black children in accessing transplants. So I just want to help people remember why this is so important. And I think one of the things that I'll say about thinking about these questions in pediatrics is really thinking about how important transplant is for children, right? How significant the problems with growth and development are when children are on dialysis versus when they have a functioning kidney transplant. So we're weighting transplant really heavily differently in pediatrics. So for kids, we have disparities at every single step of this process, right? So at diagnosis, we know that Black children have less time between diagnosis and first renal replacement therapy. We know that Black children are far less likely to receive a preemptive transplant. We know that Black children are more likely to end up on hemodialysis versus peritoneal dialysis. That's significant in pediatrics because if you think about a typical school year, for all those of us who have kids, typical school year is 180 days. If you're on 3 days a week dialysis, that's 152 days a year, 156 days a year. Most kids are actually on 4 days a week because their bodies are smaller, and so it's a little bit easier if they're on 4 days a week. That's 208 days a year in the hemodialysis unit. Our schedules, I mean, we can do a lot to accommodate a schedule, but we can't eliminate missing out on school for kids on hemodialysis. So when Black children are on hemodialysis more often, that's a really big impact on their schooling. So that's why that one is particularly significant for kids. We know that Black children wait longer to get to their transplant. We know that they're more likely to get a deceased donor rather than a living donor. And overall, they spend about 24% less time with a functioning graft. And I have a list of references at the end if you're interested in some of these. And then we know that Black children receive fewer well-matched kidneys, have lower 10-year graft survival rates. And this last statistic I think is really stunning, which is that a Black patient who starts their first renal replacement therapy before age 21 has a 45% higher risk of death. That is not okay. And in pediatrics, they haven't used a race correction in EGFR for a long time, so this isn't going to change dramatically because there are new EGFR calculations, right? Those are based on a really, really horrible idea that Black people have more muscle mass, but kids don't have more muscle mass, right? So we didn't think about making that correction in kids for a long time. So if we know that our gatekeeping system is resulting in disparities, and we recognize that our professional ethic has an obligation to fight for social justice, what is it that we should be doing to reshape our selection system? And so I'm going to spend a little bit of time talking about the 4-box model, which is a way of making ethical decisions that is used often in medical settings, and think about whether there's anything we could learn from that model that might help us think about how we reshape transplant selection. And I don't have a brilliant answer for you about how we reshape it. I wish I did. I wish I had the key to it all. But this is what I'm hoping that you walk away from is thinking about some of these questions for yourself and for your transplant team. So are people basically familiar with the 4-box model? Is that something that you all know? Okay, I see some nods and some shakes. So this model is used to help make complex medical decisions. We used it at Seattle Children's a lot for complex medical decision making. Usually it involves collecting a team of people, which includes the providers involved, the family members involved. If the patient is capable, the patient can be involved. Oftentimes these are happening when a patient is maybe not able to be speaking on their own behalf, either because they're an infant, in my case, or because they are intubated or not conscious in some way. So, but the idea is to think about the whole person, the whole child, in my case, the whole person, and think about all of the ways that we provide, that this medical care that we might be providing impacts a person's life. And so there are 4 boxes, which is why it's called the 4-box method. The first box is about medical indications, in which you sort of think through all of the things that are happening medically for the person and what particular treatment you're trying to decide about or against. Patient preferences, we're trying to identify what does the patient want. And when we either have a minor child or someone who is not conscious, then we have to figure out who is a good surrogate decision maker on their behalf. We want to think about quality of life. So what is their quality of life now? What are the potential quality of life issues after this treatment decision that we are thinking about? depending on which way we go. And then there's this box for contextual features. And one of the things that shows up in contextual features are things like, are there issues of social justice that we need to be taking into consideration? So I'll go quickly through these first three, and then we'll think a little bit more about the last one. So for medical indications, you work through things like the diagnosis, the prognosis, the treatment options, the benefits and harms of those treatments, chronicity versus acuity. And, so this is a place where, we hear a lot of sort of more factual information, hear about what we know about the treatment choices and what likelihood of success there might be. And then again, in patient preferences, we're thinking about who has informed consent, who couldn't be a surrogate decision maker. We're thinking about things like, can the patient manage the care that they want, right? Can they provide the self-care needed to achieve the treatment choice that they're looking at? We want to know sort of who else is a stakeholder, essentially. For quality of life, we're wanting to think about what impact will the treatment have on the person, what will not offering the treatment have on the person in terms of quality of life, things like pain, things like physical capabilities, occupational health kinds of things, ability to enjoy activities of life that have been a part of their lives before. We think about how to offer a quality death in this box, right? If we're thinking about a situation in which a choice not to provide treatment means a choice of ending life. We think about palliative options here. And then when we go to contextual features, we're thinking about things like, is there a conflict of interest involved in this decision? So do we have a physician who's pushing a medical device that they're a part of develop? Is there a research project that they really want one more patient to be a part of? Is there a parent or a caregiver who is pushing something based on their personal needs? If I can be a caretaker, if this person gets this care, then I get paid as a caregiver for them, and so I want them to get that. Those kinds of conflicts of interest we want to think about. We want to think about financial impacts of these, cultural and religious factors that might be important. And then we're focused on things like social justice and things like fairness. And I think that's where we often in routine conversations, we leave this part out, right? This contextual box. I think when we have conversations with patients about treatment and about care, it's not uncommon to go through those other things, the medical indications, the patient preferences, and the quality of life. Those are pretty straightforward for us. We think about those a lot when we have conversations. We work with interdisciplinary teams, so we have really good, well-rounded ways of having those first three boxes attended to in routine conversation. But we often forget this one. And I think maybe there's a way we should start to bring this piece back into our conversations. So I want to think about, is there anything that this model could do to better serve us in transplant, right? So we could potentially think about, is this something that we should use in every individual case that comes to transplant selection? Essentially, every transplant selection case is an ethical dilemma. It absolutely is an ethical dilemma. And so why not use an ethical tool to help us make those decisions? Should we use something like that as part of our selection process, thinking about all of those categories of things more carefully than we do? I think we touch on a lot of them. A lot of selection teams with the interdisciplinary team, you get to a lot of content there, but I don't think we then look at it as a whole picture. And this might be an interesting way to organize the information that we're talking about and thinking about. And if we really consider that every single case is an ethical dilemma, then we should maybe be using some more ethical tools. I I think it would be interesting to think about whether this is a model that could help us redesign the selection process, right? If we were going to start from scratch and build selection criteria, could we use this four-box model as a way of thinking what is relevant and what is important to be thinking about? We could think about the medical indications. We could think about, yeah, we still think it's probably a bad idea to give organs to people with terminal cancer, so we're going to have that as one of the medical indications that is still a good rule out for now, or a postponement or whatever. We have lots of things we could put in that box. We could think about the patient preference, right? We could talk about their desire to have a transplant. We could talk about all of the things that are a part of that. We could put in that box things about living donation versus deceased donation, timing of transplant, how it fits into the rest of their life. We already talked some about quality of life, and I think we could find some ways to really think more carefully about how that impacts our selection process. And then I think it would be really valuable to have, as part of our selection process, questions about social justice and fairness. Is this a patient who fits into a category that has been historically marginalized in transplant? How do we want to consider that? How do we want to consider how that has impacted this patient? Have they had a delay in care over the years before getting to this point in time based on race-based clinical algorithms in medicine, right? And we may not have concrete notions, but I think it might be really interesting to think about using that in a broader context and using it as a way to rethink what should our criteria be and why? Why are we using that criteria? So, one more question for you. What word or phrase comes to mind for you when you think about the ethical principle of social justice in the context of your work as a dialysis or transplant social worker? Or if we have non-social workers here, whatever your role is. We're not getting the word diagram here, but I'm seeing advocacy, equity, patient-first mentality, life-changing, looking for balance, fairness. These are all amazing words, right? Removing barriers, predicting the future. Yeah, fantastic. Sorry, it's not coming up in the nice, pretty diagram it's supposed to. Oh, you are? Okay, good. Good. Education, fairness, yeah, these are all great. Safety. So I have a couple more slides that I want to share and pose some questions to you, and then I'd like to be able to open it up to some question and discussion before we end our time together. So I think that questions that I want to ask. So I have our ecological systems diagram up here on the left because I want to remember that as social workers, we are systems thinkers. That is our skill set. We are good at that. Hospitals are big systems. Healthcare is a massive system. We are good at thinking through this, and that is part of our psychosocial expertise. And that is something that we bring as a psychosocial expert to the transplant selection team. And this is something that I think we need to rely on more. We need to be talking through how we understand the systems connections for the individuals that we're thinking about, and how our selection process it continues to facilitate problematic oppression for some people. And I think this is a way to do it. All right, we can think like systems thinkers, and we have some language to talk about it. So what I want to ask are things like, is there room in the transplant selection discussion to talk about racism? Is there room at that table? It's a busy time. Everyone's got lots on their plate. Is there room for that topic in those conversations? Is there room to talk about social justice at that table? We have been invited to this table. We have a seat at this table. We bring an expertise to this table, and I want to make sure we are using that voice effectively and saying the pieces that I think need to be said, and we are the ones to bring it to that table, right? So what other pieces of our expertise do we need to bring to selection? So my hope as you walk away from this is that you will keep in mind for yourselves, what are the big ethical frameworks that are shaping my decisions? What are the principles from our code of ethics that apply to this particular situation or this group of situations? What ethical concerns do I have if we say no to this patient? What ethical concerns do I have if we say yes to this patient? Is my priority to the organ or the patient? How do I weight these concerns? And what kinds of contextual features, that fourth box in the model, what of those deserve more attention? So I could talk about this for a long time. We have about 15 minutes left. My goal was to end here so that we could have conversation and talk. So my hope is that that's okay with all of you. So that's what I have. I appreciate your time this morning, and I'd love for there to be questions or just a chance to actually sort of share experiences and talk amongst ourselves about this. And my references are here at the end of the slides if you are interested.
So there are a couple of questions
Okay.
in the chat. Is there a record of the first minority patient who received hemodialysis?
There probably is. I personally don't know that. I don't think there were any minority patients among that first initial group of patients, but there's a really good book that I used for some of this history. It's old. It's from '78. It's The Courage to Fail, that documents that early history really nicely, and they talk some about those early patients, and I think in there they describe that there is an early black man who receives an early patient who's a black man who receives dialysis, but it was not I was not in that first group, and I don't remember when. Sorry.
Okay. Who elected the people on God's committee?
Well, so I think there was I don't know who selected the individuals, but there was a conscious decision for those occupations, right? There was an attempt to think about, it's an interesting idea, right? If you're trying to figure out, if this hasn't been done before and you're trying to figure out how do we provide care to a limited number of people, how could we cast a broad net in our social sphere to think about how different people evaluate social worth? I'll tell you, all of the members of that committee were white. The housewife was the woman. All the others were men. So it was not a very diverse group, and in terms of who they were as individuals, just professionally. There's someone behind you too, if we want to.
Okay. There's a few
Okay.
other questions. Okay. What are your thoughts on the challenges families and patients face during the transplant evaluation process?
I think for me, I go back a lot to why we have decided that it's important to make the transplant evaluation process hard. So again, I've done all of my work in pediatrics. So these are all kids who are not coming to those appointments by themselves. So it's a kid missing school, it's a parent missing work, it's siblings who need childcare, and it's on top of whatever existing dialysis schedule that child has, whether that's inpatient. We did some work to try and tag on to hemodialysis appointments, but the hemodialysis unit is not a confidential space, so there's a lot of things you can't do in the dialysis unit. There's some things you can do, but if could we just make it a longer day as opposed to scheduling on a different day? We were not great at that. But I think that's the thing that I come back to over and over again is why are we making it so hard? We are making it hard because we want it to be a test, as in my opinion. And I don't think it's a worthwhile test, and I don't think it's necessary. I don't think we should make it as hard as it is just for the purposes of seeing can they jump through the hoops we've asked them to. If we add flames, will they still jump through it? Why? So that's I think the first thing I always come back to is why is it so hard? Why do we have to challenge people and know that it's going to be, we are asking them definitely to do something challenging. where they're already taking care of a kid on dialysis. I mean, my God, what other challenge does somebody need, right? They're somebody who needs a transplant. That's challenge enough. Okay. Yeah, you want?
Hi, thank you so much. My name is Aditya Pawar. I'm a transplant nephrologist locally from Beth Israel. Thank you
Great.
so much. I really loved your talk, and it was very informational, and also it made me think of a lot of questions, and I had to ration and think of the 4-box model to which question I want to actually ask you. So I have a comment and a question. The first comment was about, it's interesting how that Sheena Alexander, I think that's what her name was.
Yes.
Who looked into this. And that was, now in hindsight, we can say, this happened. And I
Yeah.
wonder 50 years from now, somebody probably will look at what we are doing right now and say, what were these people thinking? So I wonder what this process seems to be a little closed box, like nobody knows what's happening. I mean, if you ask the dialysis center, or they probably don't know how the decisions are made. So I don't know the answer to that, but that was just a thought and comment, like maybe this needs to be opened up. But my question for you is, one of the question that you asked, are you for the patient or for the organ? Mm-hmm. And unfortunately, I chose organ. And I struggle with that. And
Yeah.
I want to understand, like, how do you see it and how do you think through this? So it's a dilemma being patient advocate while also feeling a duty to the organ. And should we make decisions for the patient in front of us versus the broader system and the fairness of using this scarce resource? And in a way, it also brings like this moral dilemma. You've made that decision, and you're like, well, I want to be for this patient, but I also have duty for this. So help me think through.
Yeah. I mean, that's a great question, and I don't expect that everybody should land exactly where I have landed. Right? We all have our own minds about this and our own experiences. So, and like I said, I went to a different conference, a transplant conference, and they were pretty focused on my priority is the organ. So you can find different opinions all over the place. I think for me, the things that I struggle about is wondering whether we have set up a system where we need to have both, and we need to make sure that we have people who are specifically the organ advocates and people who are specifically the patient advocates, and the answer, and to bring both of those groups together, but to keep them separate so that no person is doing both, right? And that might be one potential solution. I think for me, as a social worker, I go back to my ethical principles, and I am in a profession where my focus is on the importance of human relationship and my relationship to the person, the dignity and worth of each person, and I'm going to always prioritize a person. An organ is an organ, and it comes from a person, and we need to value the life that that person had before that organ came to us, or the living person who has genuinely given that organ. But my priority, I think, always has to be to a person who is in need of care in this moment. And I think that's the dilemma again, I started a long time ago where Seattle Children's, as a pediatric hospital, was doing the living donations at our pediatric center with the same providers doing the living donation, the living donor surgery and the recipient surgery. It was a mess. We were like all over the place. We all had way too many roles and way too many parts of that. So whatever we can do, I think, to just separate it out is what's important. And I think I might feel differently if I worked in with a different organ transplant, right? It might feel different if I was in liver transplant or cardiac transplant. I don't know. I don't have that experience. But that's just how I have ended up coming down to this, that we are responsible as a medical center. Our duty is to take care of patients that walk in the door. And so the patient that's walked in the door is the patient who needs the kidney, right? And so that has always felt like there's a way in which that really still has to always be the priority. But again, that's how I've landed, and I welcome other people having landed differently on that.
Thank you.
Thank
That's
you.
very helpful.
I appreciate it.
I want to make sure that I'm not taking somebody else's time, but I do have I think I've tried to think through this too, but what challenges me is because I have, let's say, 100 patients.
Yeah.
And that becomes a problem because if I'm for this patient, in that moment, but I am also going to see patient number B on Thursday. And then I'm like, well, if this organ is going, it's rivalrous because it's not going, if it's a yes to someone, it's a no to someone. And that kind of struggles me. It's a dilemma. So
Yeah.
I don't expect an answer, but just, I haven't landed to a good position right now.
Well, I think that, this is why I mentioned these 3 ethical frameworks, right? Like the utilitarian framework is trying to look at the broader good, whereas the deontological framework is looking at the patient in front of you in isolation, right? What does this patient need? And I can't take their needs into consideration based on these other people from that framework. And then our feminist framework of how do I best care for that person, right? So that's part of our problem is we're drawing on these conflicting frameworks to make parts of our decision here and a different part of our decision there. So I think it's appropriate that you're confused about that. Thank you
so
very much.
Yeah.
Yeah.
As a transplant social worker, one of the challenges that I have from an ethical, moral perspective is when I have a patient in front of me who has gaps in their preparedness, and yet there are few to no resources to fill those gaps. And so the patient will do better with a transplant, but only if they have X, Y, and Z.
Right.
And X, Y, and Z doesn't exist either in their immediate community or our larger social community. So it's a very hard place to sit in many situations.
Yeah, absolutely. I do not in any way pretend that there are easy answers to any of this, right? And I will say that working in a pediatric center, everything is housed in one building, right? The dialysis clinic is in the building, the transplant center is in the building, the inpatient unit is in the building, the outpatient clinic is in the building. I can walk across the hall and talk to the transplant social worker, and so it becomes easier to coordinate way before they get to transplant referral, how to start building on the supports that are needed. But generally, I think we don't do a very good job of that. Like we need to bring dialysis and transplant social workers together way more to be building those resources and those support systems and those skill sets really, really early. I think one of the things that has always struck me is how completely different it is to take care, again, in pediatrics. So when I think about this as parents taking care of children on dialysis versus as a transplant, right? In dialysis, it's all by sort of intuition and feel, right? I drank too much. I will need to take more off during my dialysis session. I'll need to put a different bag on the PD machine at night. I'm going to take an extra binder because more phosphorus was in my dinner tonight. You have a sense of how to take care of your body by touch and feel, or your kid's body by touch and feel, right? Whereas transplant, you know nothing until a lab result tells you to do something different. That is a really big shift in mindset. And I think we need to build those kinds of skills early for dialysis patients, because it's very different from how they take care of themselves before they get there. But yeah, I don't have an easy answer because and we're about to see everything stripped away for resources, right? We're about to really have nothing. Sorry, yeah.
Thank you. First off, this was a wonderful presentation. My name is Amanda Martinez. I'm a transplant pharmacist, and I've worked at 3 different transplant centers across the United States. So I've had the fortune of seeing how other places do it.
Yeah, nice.
And one thing that has been a common theme is a reluctance of non-physician committee members to not speak up.
Yeah.
So I'm curious what your advice is for programs to inspire team members to do that, because it can feel, I think, a little tricky when you're working with these people who may have an element of superiority over you.
Yeah, it's awkward, right? To be in a setting where you're wanting to be collaborative, but you're in the midst of a very hierarchical system, right? And so we revert back to that hierarchical structure so easily. I mean, I think you can think about a lot. I mean, I want to try and encourage every social worker to say, I am the psychosocial expert here at this table. I've been invited to this table. I have a voice. I have an opinion. Same for the pharmacist and the nurse and everyone else who's there. And that can work or not work, right? Depending on who you are and who your teammates are. But I think there are ways you could structure your selection team meetings so that there is designated time, not just do you have a comment, but these next 5 minutes are for social work. What do you need to talk about? This next 5 minutes is for pharmacy. What do you need to talk about? And make sure that it's not just like, do you disagree? Right, you're not already presuming to know what the other person has to say, but you're really inviting thoughtful discussion and ideas. And it's possible that it would be easier to ask questions on both sides. Like, tell me why you think this patient should get transplanted. And everybody goes around. Tell me why you think this patient shouldn't get transplanted. Tell me what you think the consequences are if we say yes, if we say no. Like, maybe we should just restructure how we are talking about it. Like I said, I don't have brilliant solutions, but I think it's worth continuing to have these conversations. Like, how do we set up our team meeting differently so that we encourage more voices to be heard? Yeah, thank you.
Sure, and to just follow up on that
Yeah.
one, do you think there is a role for UNOS and CMS to provide more structure in the committee selection setup and how we run our meetings?
I mean, I think one of the problems we have right now is that we all do it differently, right? And so that's a struggle where, one center has one set of rules and a different center has a different set of rules, and different personalities, different levels of experience get brought to the table. So there's a way in which there's a temptation to think about some kind of unifying structure, which UNOS or CMS could do. I will say right now that feels really scary to think about any particular governmental agency getting to have the say on how things are done. So I just want to be careful about how we think about that. But I do think it's a problem that we all do it differently, that we don't have, to some extent, we all have different settings, right? I mean, there's something that's so unique about Seattle Children's. We serve Washington, Idaho, Alaska, and Montana. We've got kids living in Alaska who are only accessible by boat or seaplane, and you have to make different decisions about them for dialysis and transplant. That's really unique. That's a unique setting for us, right? And so we can't do everything exactly the same as a different center where there are 4 transplant centers in the same city that people can choose from. So some sense of figuring out how to be more consistent is, I think, really critical. But that's my hesitation about those 2 organizations at the moment. Okay, we have 1 more minute if anybody else would like to say something or ask something.
I just wanted to say thank you. I'm a transplant patient, and for doing this presentation, you opened my eyes to the behind the scenes,
Yeah.
getting to see how those decisions are made. And I want to say I'm proud of you for making this presentation, opening the door and saying, like, you know what, let's change the way we ask those questions. Because how we ask those questions and look at a patient overall changes someone's life like me.
Yeah.
That it helps save my life. And so maybe the question needs to be, what if this person gets something? How can we make it an even playing field? Because it saddens me to think that I did PD and that there's a child out there who is Black and would not get that opportunity.
Yeah.
Like, how can we change that? So I just want to say thank you.
Thank you for that. And I didn't say as much about this as we should have, but I think bringing patients and patient advocates into the process is really critical. We are not doing that enough. We think we know what it's like post-transplant for people. We think we can predict who will do well post-transplant and who won't, and we're not always right. And we don't take enough information back from patients about that, about what it is really like, what it is like to transition from dialysis to transplant, what that shift is, and what would be most helpful in preparing for that shift. Yeah, thank you very much. Appreciate it. Thank you, guys. I really have liked talking with you.